Hello everyone, thank you for joining us for 292 Baby educational videos, support for parents and caregivers of infants. I would like you to know that all of the experts featured in our video series have given freely of their time and all are from the early childhood community of Greater Rochester. On behalf of everyone affiliated with the 292 Baby Project, we wish you the very best of luck with your children. "292 Baby" is a community collaboration administered by Monroe Community College.
I'm Pam Herendeen, and on behalf of 292 Baby and the March of Dimes, we are pleased to collaborate today with Dr. Patricia Chess. I am a pediatric nurse practitioner at Golisano Children's Hospital at Strong, where Dr. Chess is a neonatologist. If you would like to tell us a little more about yourself.
Yes, I am a neonatologist at Golisano Children's Hospital. I was actually born and raised in Greece, so I'm very familiar with this community, and came back here because I wanted to provide optimal patient care to the babies in this area. I did my training in New York City and really wanted to come home. And one of the things that I noticed after practicing here for a number of years is a repeating theme that I found rather concerning, in that there were babies who were being delivered slightly before 39 weeks against the American College of OBGYN guidelines, and there are inherent risks in that choice. And what I found in speaking with the mothers was that sometimes they weren't aware of these risks, and in speaking with some of the OBs in the community, they also weren't aware of these risks. So I became very interested in educating both the healthcare providers and the families in our community about the risks of delivering a little bit too early and when the optimal timing for elective deliveries are.
So it used to be, many years ago, that we kind of depended on nature to deliver our baby, and then recently I have noticed a trend just from the babies that I see in the pediatric practice at Strong, as well as just friends in the community, where C-sections seem to be planned, almost at the convenience between meetings, the convenience of both the obstetrician and the mother. Is this kind of what you're seeing?
There is an increased risk in C-section deliveries.
Mm-hmm.
Part of that is because we're getting better at monitoring babies, and we get babies out if there are signs of problems.
Mm-hmm.
But once you've had a cesarean section, although you can have a vaginal delivery after a cesarean section, many mothers choose to have C-sections with subsequent pregnancies, and those elective C-sections are scheduled in advance. And the American College of OBGYN, or ACOG, recommends not to schedule those before 39 weeks, but when you consider all factors, the OB's availability, mom's availability, mother-in-law coming in to help out the baby, mom being uncomfortable because she's getting further and further along in her pregnancy, that number's slipping down to 38, 37, sometimes even 36 weeks, and that can lead to problems with the babies.
So I guess we all take when someone is pregnant and they're having any problems, we think, okay, if they can just make it to 36 weeks, 37 weeks, we're okay, but that may not necessarily be true, so maybe you can tell us some of the risks of delivering early.
Right, I actually have some information on some slides that I'd like to review. So this first slide was actually put together by the March of Dimes, and it shows that for tens of thousands of years, the average gestation in humans has been 40 weeks. And within the past 10 years, we've actually shifted the average gestational age of humans to 39 weeks. Now, some of that is because of the improved monitoring that I spoke to you about earlier, but a lot of it is the choice to deliver a little bit early. If you could go to the slide after that, please. So the top two lines here, the darker line is 2002, the line behind that is 1992, and those are cesarean sections. Those bottom two lines are for inductions. Again, the top darker one being 2002, the bottom one being 1992. And as you go from the left to the right of the screen, the gestational age, or how old the baby is at the time of delivery, goes up. And what this is telling you is both elective delivery is increasing and cesarean section delivery is increasing. And again, part of this is a risk of medical factors, but part of it is moms being uncomfortable or optimizing schedules. So the next slide will review some of the medically indicated factors to deliver. If there's a problem with the placenta, which supports the baby, and it's positioned over the cervix, that can be a problem, and cesarean section is indicated at that point. If there's evidence of infection, if there's maternal indications that maternal medical issues are getting worse, if there's preeclampsia, which is an elevation of blood pressure in the mother associated with some other issues, if there's premature rupture of membranes and an increased risk of infection, if the baby isn't growing well, if there are multiple babies in the uterus, if there are fetal congenital anomalies, male development of the fetus that makes a medical indication for delivering early, poor placental function so that the placenta isn't providing nutrients to the baby anymore, or if there's a problem with anemia that's putting the baby at risk. These are some of the medical indications for delivering before 39 weeks. But there are more and more cases where none of these medical situations exist, but there's a choice to deliver before 39 weeks.
And so if you were to deliver electively for no medical reason at 37, 38 weeks, what kinds of things could possibly happen to the baby that would be an adverse event?
If we could have the next slide. So just briefly talking about the rates, the numbers that we're talking about, both in our community and nationally, 30% of births in this country are by cesarean section at this point. And a trial of labor after a cesarean section is not without risk, so many OBs and mothers are choosing not to go that way. So up to 50% of cesarean sections are repeat cesarean sections, where a mother and an OB get together and decide when to have their delivery. So 10% of infants in the United States are delivered by elective repeat cesarean section, where the date of delivery is chosen in advance. If we could go back to that. So there are also inductions for non-medical reasons are also on the rise, related to things like maternal schedule, maternal discomfort. Mom's made it through 8.5 months of pregnancy and she just doesn't want to be pregnant anymore. She can't see her feet, she can't sleep at night. She's anxious because she's not sure that the baby's doing well, and she'll feel better if the baby's on the outside where she can actually see the baby. There's also OB availability. A lot of OB groups are quite large now, and they rotate when the OBs are on call. So if you have an OB group with 10 providers, and your provider is on call tonight, but not again for 2 weeks, you may decide to schedule a little earlier because they're going to be available.
And everyone has their favorite OB, so that is a very popular decision to do.
Exactly,
yes.
exactly. So you have to weigh the risks and benefits. Right. And the next slide will get at some of the information that gives both the care providers and the families reassurance about why this may not be so horrible, because we're very good at what we do in the NICU. And even babies that are born as early as 27 weeks in our community have a 90% chance of survival. So when you say 28 weekers, most of them do well. By the time you're 37 weeks, you're out of the wood. But there's more and more information saying that's not necessarily the case. There's increased risk of transient tachypnea of the newborn, where you're breathing fast. Respiratory distress syndrome, where you have not quite enough of something called surfactant in your lungs, and to treat that you might need to be put on a breathing machine and be given supplemental surfactant. Temperature instability, where the baby doesn't have quite as much meat on their bones as if they waited until term, and so they have low temperature. Hypoglycemia, or low blood sugar. hyperbilirubinemia or jaundice that needs to be treated with phototherapy, which means either a longer time in the hospital, or there's an increased risk of these babies going home and needing to be readmitted for phototherapy. There's a higher rate of rehospitalization for feeding problems. There's increased risk of apnea and SIDS, sudden infant death syndrome. And there's also been documented that the brain isn't fully developed if you deliver even just a few weeks prematurely.
This is really interesting because I know as a pediatric provider, when I see a baby and see the 34-week or 35-week, I take a sigh of relief and say, okay, she was preemie, but we're really out of the woods, and this baby is going to do great. And a lot of them, of course, do great, but the long-term sequelae and some of the subtle abnormalities may not even be evident to us.
Right, and I don't want to scare parents who've had premature babies because you're right, a lot of our premature babies do very well. And some of these things are very subtle, but why choose to put your child at increased risk if you don't need to?
Exactly. It certainly is something for our community to be thinking about, and for both our medical providers and parents that are planning babies too. It will certainly give me pause to think about some of anyone that I'm talking to who is pregnant and say, gee, you know, I have a scheduled section at 38 weeks. Well, have you really thought about some of the, are you even aware of some of the risk factors that are involved? And a lot of people aren't.
Correct. And I've had mothers who've come in at 38 weeks and their babies have ended up on the ventilator with immature lungs, and the mothers say, if I had only known, I would have waited a few more weeks.
Right. And even the jaundice, I see so many children that end up coming back into the hospital and have to have the Billy lights for their jaundice, and you wonder if they were 39 or 40 weeks rather than 37 or 38, if that would have happened. And now that I'm hearing, probably not. They may not have needed that readmission. So there's certainly an economic factor as well as a hardship for the family to have to bring a baby back to the hospital. So well, that's interesting.
And you talk about most of the babies that you deal with that are born at 34, 35, 36 weeks do quite well. I actually have some other pieces of data that show that you really do need larger numbers to show the difference, but the differences are real. So this is from a study that was published in the British Medical Journal in 2008, showing that if you delivered electively by cesarean section at 37 weeks, you had a 10% chance, so 1 in 10 chance of your baby ending up in the NICU. At 38 weeks, you had a 5% chance, but by the time you got to 39 weeks, it was only 2%. So you really have a significant decreased risk of your baby ending up in the NICU, and an increased risk of, on the other hand, keeping your baby with you, which is what everybody wants.
Of course.
And there's some other, so this one is looking at a Scandinavian study, which I thought was fairly interesting. A lot of my colleagues thought this was interesting because the advantage of looking at Scandinavian data, because it's socialized medicine, they keep these huge data sets, so hundreds and thousands of babies. And when you look at data sets that large, there are actually statistically significant differences in the the percent of individuals that ultimately go on to high school, college, postgraduate education. There's increased risk of, as adults, having children still living at home if you deliver at 37 or 38 weeks compared to 39 weeks. So things that, when you look at a smaller community, you wouldn't really be able to tease that out. But when you look at larger data sets,
and they've looked at it for a long period of time, so that's a really an advantage to be able to look ahead for many long-term studies.
Right. And some of the other things that are fairly compelling is something called ECMO. ECMO is extracorporeal membrane oxygenation, and this is a very unique system where if a baby is critically ill and their lungs and their heart are not functioning, we can actually put them on a heart-lung bypass. And we have this availability at Golisano Children's Hospital. I'm actually the medical director of ECMO. And we report how the babies do to a national registry, the Extracorporeal Life Support Organization. We don't attach names, but it's important to follow how these children do so we know if we're doing an optimal job. And if you look at the trends from that information, you'll see the top bar is elective cesarean, Actually, no, the very top is the normal spontaneous vaginal delivery. So that number has remained somewhat constant over the years. The middle lighter bar is the emergency cesarean section deliveries, and you'll see that number is getting smaller and smaller. And overall, the number of babies needed to be treated with ECMO is going down. But what you'll notice on this is the bottom dark bar is getting bigger. And what that's saying is there are more babies that are delivered by elective cesarean section needing heart-lung bypass support. And we're talking major support. This is a very high morbidity, high mortality intervention to keep these children alive. And if you look at the data more specifically, the center red box that says EC, these are babies that are delivered by elective cesarean. So somebody is choosing the time when to deliver them. If you deliver less than 39 weeks, your rate of death, your percent mortality is twice as high as if you deliver electively after 39 weeks. And to really hit that home, the next slide, this is actual numbers of babies. So if you look less than 39 weeks versus greater than or equal to 39 weeks, the number of babies that are that have died when delivered electively before 39 weeks is double that of those delivered after 39 weeks.
That's a very startling number.
Very compelling.
Very
Yes.
compelling. So this certainly is something that would be important to get the word out to the community and to the medical providers. Do you think that, I think that a lot of people aren't aware of it. What do you think about it?
I'm sure people aren't aware of it
Yeah.
with the discussions that I've had with OBs in the community and healthcare providers, but with this initiative, more and more people are becoming aware of it. And I know I'm kind of hitting a hot button because I've been contacted by USA Today and ABC News, and I've spoken on this topic because it's recognized across the country that this really is a major issue that is that we are creating. We are choosing to deliver just
We
a little
are.
bit earlier, and it's leading to major issues.
So we were talking about it is best to wait to 39 weeks for delivery. So is more better? 40 weeks, 41 weeks, 42 weeks? Where do we draw that line?
Yes. Too late can be just as bad as too early,
Okay.
actually. So we do have information related to optimal timing on the 39 week as well as on the further side. So you really want to schedule in that 39th week, because if you wait past 40 weeks, the chance of going into labor spontaneously if you need a repeat cesarean section goes up. And if you wait past 41, 42 weeks, you actually run the risk of outgrowing your placenta. And there's increased mortality after the 42nd week. So if you could pull up the next slide, this is mortality data. And you can see at 34 weeks, this is the mortality rate out of 1,000 births. So 12 out of 1,000 at 34 weeks. By the time you get to 39 weeks, it's 1.2 out of 1,000. At 40 weeks, it's 1.7. But if you get up to 42, it's 6.5. So you really want to schedule it in that 39, 40 weeks if you're choosing when to deliver.
So that really is an optimal time then that needs to be worked out if you're choosing your delivery.
Right.
So, of course, all the obstetricians want to do the right thing. Is there an organization or are there some guidelines that are available to help guide